Good morning, chairpersons and delegates, and thanks to the organizers for this great opportunity. I'm going to talk about a case where I burned my fingers in a saphenous vein graft intervention, which was complicated with no reflow. The morning just before this, we had a discussion about how to manage no reflow, and this we tried all the things which are presented here, but this patient ultimately ended up with an inferior wall MI. My patient was a 72-year-old gentleman, was a dyslipidemic, ex-smoker, anterior wall MI in 2000, and a bypass surgery done in 2000, the Lima to LAD, a vein graft to diagonal, OM and RCA. He presented with a non-ST elevation MI on 1/9/2014. In our practice, any patient who presents with post-CABG, who presents with ACS, we normally subject them to a 64-slice CT, and this is what we found. The vein graft of the RCA had a critical stenosis with thrombus. It's not seen here in this, but the MIP images did show a huge thrombus burden in this vein graft. The other grafts were patent, and so having seen this thrombus burden in the vein graft, we decided that we should give him upstream eptifibatide infusion a day before the procedure. And then we had to plan our strategy. We had to use distal protection, seeing the huge thrombus burden. And since we are very familiar with this embossed shield about filter wire, which we use in carotid intervention, so we decided we will use an embossed shield filter for distal protection. And we also had to use manual thrombus aspiration, considering the huge thrombus burden. And we were prepared to do a direct stenting, and we had all these vasodilators on board: adenosine, sodium nitroprusside, nitroglycerine, and nimodipine. How do you play it? Yeah. This is the vein graft of the RCA. You can see the huge thrombus burden in this vessel, and this is the picture with the distal filter wire in place, and can you play it, please? Yeah, you see that despite giving despite preloading with eptifibatide, the thrombus burden was still huge. And see the picture on the right shows the manual aspiration done with a 7 French export catheter. It was done, multiple runs were made in the beyond the thrombotic lesion, and this was with the filter wire positioned distally. Can you play it, please? Yeah. This is again the picture on the right. This is a picture with the direct stenting in place. It's just playing for a short while. So this, after direct stenting, we found there's complete no reflow. There's no flow beyond the standard segment. And then we gave this cocktail. We put a microcatheter distally, and then infused intracoronary adenosine, high dose of intracoronary adenosine, close to 400 micrograms of adenosine. It didn't work. Then we gave intracoronary nitroprusside up to 300 micrograms. It didn't work. And then we gave verapamil. It also didn't work. And then after that, we thought, since maybe the filter wire was clogged with thrombus, so we again did multiple runs of thrombus aspiration with the thrombus export catheter. Can you play it? Yeah. Again, there's no reflow again. The flow didn't improve, and so we had to do repeated runs with the thrombus aspiration. It didn't improve. The patient had ST elevation in the inferior leads. He had pain, And we had to give him, we had sedate him and then continue with the manual aspiration as we see here. Now, whatever we did, despite multiple runs of thrombus aspiration, liberal cocktail use, the flow didn't improve. And then this was the picture with the no free flow. We decided to dilate the stent with a 4x8 NC Trek balloon. That didn't make any things better, and still the flow was grade 0 flow beyond the standard segment. This is a final picture. We left it at this because patient, the no reflow did not improve at all with whatever we did. And the patient eventually settled down with an inferior volume I. And he, post stenting, he had multiple issues, like he had a high-grade EV block which required temporary pacing for a short while. He also had hyponatremia, which responded to hypertonic saline, and eventually he left the hospital, and he is doing well after in the 4-month follow-up period. So the take-home messages I want to impress upon this audience is that if you have faced a situation of a chronically degenerated vein graft, which is a great huge thrombus burden, it's better that you don't touch it and touch the vein graft, rather opt for opening up the native vessel if it's possible. In our patient, this RCA was a chronic total occlusion, and it didn't appear to be a great vessel for intervening. And there are some studies which report on the IVUS predictors of no reflow. If you had done IVUS and if you had seen a huge thrombus burden or a massive plaque or a multiple thrombus, then I think the patient would have been left alone rather than intervening in this patient. Thank you very much for your patient hearing.